What's up, guys? Today is July, what day is it? It's July 10, 2024. I'm taking step two in 9 or 10 days. So it's coming up. The anxiety is also coming up. Got to do some studying. So the plan for today is to review pediatrics because when I took UWSA2, the UWorld practice exam on Friday, my weakest section was OB-GYN at 33%. So I spent some time reviewing that already. And now I'm going to review pediatrics, my second weakest section, which was at 52%. So that's the plan for today. I'm going to do a block of UWorld with you guys, pediatrics. But before I get started, though, just a quick reflection, which is that yesterday, I was hoping to get a lot done yesterday afternoon. In fact, I didn't leave home yesterday because I thought I would save time that way. Um, I, I mean, so what I was going to do in the afternoon was like review all of MBME 13, which was a practice exam I took a while back, and I wanted to go back and look at it again. But what ended up happening is, some people I know had some car issues, and I had to go help them, and so I lost maybe like 2, 3 hours of my day from that. So, so even when you're at your most productive, you still lose a lot of time. But I'm not gonna let that hinder what I've been doing. So I lost a day in kind of reviewing MBMEs because I didn't get through most of that exam, but that's okay. That's okay. I'm just gonna keep grinding and keep studying. So with that, let's get started on pediatrics. So I'm gonna review the unused and incorrect pediatrics questions, total of 388. Um, I'll do all systems, 40 questions. Let's go. And then tutor mode. Yeah. All right, let's go. 14-year-old boy is brought to the office by his camp counselor due to a tick bite. He arrived at a summer camp in Vermont earlier today and spent the afternoon outdoors. About an hour ago, the patient noticed a tick attached to his right thigh. He has no fever or pain at the site and has no chronic medical conditions. Vital signs are normal. Physical exam shows a small brown tick attached to the right medial thigh with an area of erythema 3 millimeters in diameter. The remainder of the examination is unremarkable. What is the best next step in management? Allow the tick to detach spontaneously and obtain Lyme disease serology. Apply petroleum jelly and prescribe doxycycline. Crush the tick and prescribe single-dose doxycycline. Puncture the body of the tick and prescribe amoxicillin. Remove the tick with a small forceps. All right, so there's this thing where like in kids you don't want to give doxy because it like changes the color of their teeth or something. But this kid is 14, so I feel like he's old enough to get doxy, right? Um, and then I guess maybe we don't want to crush the tick or something. That's just something I remember from I don't know when that like you're not supposed to because like the head of the tick can remain inside or something. Um, so empiric treatment makes sense to me, but like just treating for 21 days without any testing is also kind of weird. Um, so I'm kind of stuck here. I'm gonna go with A. Okay. So ticks should be removed with a small forceps as soon as possible to reduce the risk of tick-borne illness. If the tick is attached for less than 36 hours, then antimicrobial prophylaxis is not required. Yeah. So the tick here was only attached for what? Um, less than a day, right? And so if it's attached for less than 36 hours, you don't have to do anything. So I didn't know that. So I'll make a card on that later. But yeah, and then otherwise, for choice A, no, you want to remove ticks as soon as possible. So you want to use the forceps. You don't want to leave it on there. You shouldn't use petroleum jelly to remove a tick. Okay, next question. A 2-year-old boy is brought to the clinic by his parents for a routine well-child visit. He has no known medical conditions and is growing and developing appropriately. The patient is starting to put words into sentences and sleeps well at night. Good, good, good. Diet consists mostly of cheese and yogurt. He drinks approximately 5 8-ounce cups of whole milk each day. 2 months ago, the patient's family moved from Greece to the United States. No allergies and immunizations are up to date. Height and weight are at the 25th percentile. At temperature is 36.7. Conjunctiva and mucous members are pale. Lungs are cleared auscultation bilaterally. Cardiac exam reveals tachycardia at a 2 out of 6 systolic murmur along the left upper sternal border. Hemoglobin is 8. MCV is 70. So he has microcytic anemia. Erythrocytes, I don't know. I think that's not a lot. Normal erythrocyte count is like at least 4.3, so his erythrocyte count is low. Platelets are fine, leukocytes are fine. Which of the following additional findings is most likely to be present in this patient? Abnormal hemoglobin electrophoresis, elevated MCHC, elevated red blood cell distribution with high indirect bilirubin level, increased circulating nucleated red blood cells, low TIBC. So an iron deficiency anemia, I think TIBC is high, right? So it's not F. Um, and then the E, I think E is referring to reticulocytes. I don't know if reticulocytes would be high in iron deficiency anemia. That doesn't make too much sense to me because, like, I don't know, maybe it does. So maybe it's E, maybe it's reticulocytes. Indirect bilirubin would mean that there's like hemolytic anemia, which isn't happening. This RDW is also confusing me here because I keep forgetting, is RDW high or is it low in iron deficiency anemia? I think it's low. MCHC will be elevated in hereditary spherocytosis, and that's not this. And then abnormal hemoglobin electrophoresis would be like thalassemia. Oh man, but the patient's family moved from Greece to the United States, so it could be thalassemia, right? Hmm. So it's either A or E. Could it be thalassemia? I feel like because his diet is literally just whole cow's milk and like a bunch of like dairy, it's got to be iron deficiency. So I'm gonna go with that, and then that would be what? E. All right, let's go. Let's see what happens. This RDW stuff, man, I keep forgetting it. So an iron deficiency anemia, RDW is high. So two questions in a row where I just need to know these facts. If Lyme disease is less than 36, I mean, if a tick is attached for less than 36 hours, you're good. You don't have to do any treatment. In iron deficiency anemia, RDW is high. So these are just facts I need to know. Okay. Nucleated RBCs are immature RBCs found in the bone marrow. Presence of those RBCs in the blood indicates significant marrow stress, like in hemolysis or myelofibrosis. So no, we would not see nucleated RBCs. Um, and then beta thalassemias are common in Mediterranean ancestry and present with microcytic anemia, abnormal hemoglobin, and low RBC distribution width. So this kid is from Greece, but his dietary history makes IDA more likely, like iron deficiency anemia more likely. And then, yeah, okay, next question. 2-year-old boy is brought to the emergency department by ambulance due to convulsions. This morning, the patient was sitting on the sofa at home when he suddenly developed rhythmic movements of both arms and legs that lasted about 3 minutes. He was not responsive during the event. Emergency personnel report that the child was sleepy and seemed confused when they arrived. So that's the post-ictal state. Patient has had rhinorrhea for the past 2 days and fever since this morning. So could it be a febrile seizure? He has had no cough, vomiting, or diarrhea. The patient has no chronic medical conditions. His uncle has epilepsy. Temperature is 39.2. So the kid has a fever. Physical exam shows an alert and playful toddler, bilateral conjunctiva, clear rhinorrhea. Neck is supple. Mucous membranes are moist. Cap reflow is fine. So after treating him with acetaminophen, what else should we do? I think with febrile seizures, brain imaging, electroencephalography, hospitalization, levetiracetam, like Keppra, lumbar puncture, reassurance and discharge home. I think you just reassure with febrile seizures. So, okay. So febrile seizure is a fever, typically with viral illness, occurs between ages 6 months to 5 years. No epilepsy history, no CNS infection or acute metabolic cause. Um, You manage with an anti-epileptic if the seizure lasts more than 5 minutes. His was 3 minutes, and then symptomatic care otherwise. So no long-term complications, slight increased risk of epilepsy. Okay. Newborn boy is evaluated for respiratory distress shortly after delivery. He was born on an estimated 37 weeks gestation via spontaneous vaginal delivery to a 20-year-old pre-gravid mother who had no prenatal care. The mother has no chronic medical conditions and does not use tobacco, alcohol, or illicit drugs. Boy's temperature is 36.7, pulse is 144, respirations are 70, pulse ox is 84% on room air. Physical exam shows flattened facies, intercostal retractions and bilateral lungs have decreased duration. Abdomen is distended, palpable soft suprapubic midline mass. External male genitalia appear normal. Extremities are cyanotic and bilateral club feet are present. Which of the following is most likely under? So this suprapubic mass, which I think is a bladder, and the flattened facies, and then the lung problems make me think Potter sequence. But then the club feet, that makes me think some kind of a genetic issue, some kind of trisomy. So let's see. Congenital diaphragmatic hernia. And then what do they mean by this clinical condition? So what's the problem here? Respiratory distress. So could he have a congenital diaphragmatic hernia that's causing the respiratory distress? Duodenal atresia, hypospadias, posterior urethral valves, transient tachypnea of the newborn, Wilms tumor. So I'm inclined to say posterior urethral valves. Wilms would not be midline. Transient tachypnea would not be this bad. It wouldn't present with all this other stuff. Hypospadias has absolutely nothing to do with this. That's when like the tip of the penis, the urethra is like somewhere else. Duodenal atresia, again, I don't know what that has to do with this. So it's either A or D. I don't see anything which says congenital diaphragmatic hernia to me, so I'm gonna go D. Let's go. Good. So Potter sequence, you see the flat facies, you see the pulmonary hypoplasia, you see the limb deformities. So club feet, I didn't know club feet happen in Potter sequence, but they do. Okay. And then so urinary tract anomaly or PP round. So premature rupture of membranes at less than 26 weeks causes anuria and oliguria in utero, which causes severe oligohydramnios, which causes this condition. And then you get posterior urethral valves as a complication of Potter, and that causes this distended bladder and the hydronephrosis. Okay. And then let's see, congenital diaphragmatic hernia is a life-threatening defect of the diaphragm that allows abdominal viscera to herniate into the chest. And the abdomen appears scaphoid with a barrel-shaped chest. All of these other anomalies, such as Potter sequence, not that. Okay. 18-month-old girl is brought to the office by a well-child visit. The girl speaks 15 words, can run and follow simple commands. Good. So the parents place her in a rear-facing seat in the back seat and brush her teeth with fluoride-based toothpaste twice daily. She enjoys fruits and vegetables, including whole grapes, strawberries, bananas, and raw carrots. Good for her. Patient's diet also includes meats, grains, and dairy. Good. Family has gates at the top and bottom of the staircases and keeps household cleaners under the sink and a locked cabinet. They have a small backyard and are interested in ideas for summer water activities. Patient takes no medications. Vaccines are up to date. Routine guidance is what? Anticipatory guidance is what? So allow unsupervised play only in a small inflatable baby pool. Discontinue fluoride toothpaste. Eliminate whole grapes and raw carrots. Keep household cleaners in open high shelving. Switch to forward-facing car seat. The grapes, yeah, the whole grapes, that could be a choking hazard right there. Even in a small inflatable baby pool, we still want to supervise them because they can drown. Discontinue use of fluoride. I haven't heard anything about fluoride toothpaste being bad for kids. So, and then keeping household cleaners. So the household cleaners are locked. Yeah, so I feel like their kids can't really get to that. Maybe it would still be good idea to keep them at a higher shelving, but so it's either C or D. I'm gonna go with C because they can choke on those grapes. So some injury prevention things. So for water, you want to never leave them unattended. You want to fence all sides of the pool. You want to use life jackets. You want to teach the kids to swim. For fire, you want to install smoke detectors. For gun, if you have guns, you want to store them unloaded and locked, and then store ammunition separately from guns. Um, Lock medications and toxic household products out of reach, remove dangling cords and power outlets, install safety gates on stairs, set water heater to max temperature of 49, mount furniture and TV to wall, avoid choking hazards. Just an aside here, it's just sad that, I don't know, like I've read some stuff like on the news about like kids getting access to guns at home. It's just like messed up. So, and you almost want to say like, why why do people have guns? Like maybe you should just ban them, but then some places are so unsafe. That kind of makes sense. It's just kind of a tough social issue, the gun thing. But okay, next question. 17-year-old previously healthy boy is brought to the office due to progressive muscle weakness and pain. Over the past 6 months, the patient has had increasing difficulty making facial expressions, including smiling, frowning. Also has had difficulty swallowing, but no pain. Patient takes no medications and vaccines are up to date. Adopted as an infant and biological family history is unknown. Physical exam shows temporal wasting, thin cheeks, and emaciated extremities. I don't know why the lights just turned off. Um, Delayed relaxation is noted on contraction of the thenar and hypothenar muscles. Deep tendon reflexes are normal. Babinski reflex is absent. Testicular volume is normal. What's the most likely mode of genetic transmission? So what are the problems here? Progressive muscle weakness, difficulty making facial expressions, temporal wasting, delayed relaxation. The delayed relaxation, that's a buzzword. Delayed relaxation equals myotonic dystrophy. So myotonic dystrophy, I have an Aki card on this, which I keep getting wrong every single day, but I did the Aki card again today. So I think hopefully I get this right. I think it's autosomal dominance, but it could be excellent. I keep forgetting. I'm not sure, but I think it's autosomal dominant. Okay, good, good. So muscular dystrophies. Here we have the classic myotonic, right? Age 12 to 30. This kid is 17. Facial and distal muscle weakness, crib hand myotonia, cardiomyopathy, arrhythmias, dysphagia, cataracts, testicular atrophy, death at age 45 or 55. So trinucleotide repeat. This is autosomal dominant. And then Duchenne would have been X-linked recessive, deletion of dystrophin gene, age 2 to 3, or proximal muscle weakness, calf pseudohypertrophy, um, cardiomyopathy, arrhythmia, scoliosis, wheelchair dependent, death at age 23. Becker is 5 to 15 years old. It's a milder form of Duchenne. So I did actually, I went to a clinic a few years ago with, I shadowed in a clinic where they like looked at these disorders. A cardiac geneticist looked at them. It's like a heart doctor. And yeah, it's like these people are like super skinny um, because it wasn't an IM doctor, it's an adult doctor. So they were all based on this. A lot of them should like statistically should have been dead already. So yeah, it was just another one of those like really sad things, but also it kind of also inspirable. Like you can be inspired by like how strong they are and stuff too, like how they keep dragging themselves to these appointments and whatnot. So hopefully one day we'll have genetic gene therapies gene therapies for this kind of stuff. Hopefully one day. um Next question. 12-hour-old girl. So immediately I'm looking at this, I'm thinking jejunal atresia, like I said, triple bubble sign. So that's immediately my thought. Let's read the question. 12-hour-old girl in the NICU has bilious emesis. She was born at 35 weeks gestation by vaginal delivery to a 22-year-old woman who did not receive prenatal care and used cocaine during her pregnancy. She has not urinated but has had a bowel movement. Oh, she has urinated but has not had a bowel movement. Able to take 2 bottle feeds by mouth but has been vomiting green fluid since the third feed. Birth weight was 2 kilograms, so pretty normal. Okay, small. So 4 pounds, 2 kilograms, small for gestational age. 36.9, pulse, blah, blah, blah. Okay, abdomen is distended, rest of the exams abnormal. So problems with her are bilious emesis, low birth weight, and no prenatal care and cocaine. So I think cocaine actually predisposes you to this condition as well. So jejunal atresia, yeah, there you go. Triple bubble sign, jejunal atresia. Duodenal would be double bubble sign. See, so two bubbles. And duodenal, I believe, is associated with what? It's associated with some one of those diseases like I think it's associated with cystic fibrosis or something else. Down syndrome. Down syndrome. Hirschsprung is associated with also Down syndrome. It's also associated with Down syndrome. So duodenal atresia, Hirschsprung, or Down syndrome diseases. This is Hirschsprung. You see the nowhere in the rectum and distended bowel loops. Um, and then this is necrotizing enterocolitis. You see all of these like bowel loops. Okay. Pyloric stenosis. So that was choice F. That would present at age 3 to 6 weeks with non-bilious. I keep forgetting this. So pyloric stenosis is non-bilious projectile vomiting with an olive-shaped mass. Wow. Okay. Good thing we just did the last question, huh? So what is this again? If this is Hirschsprung, you see this absence of stuff in the rectum. So most likely mechanism failure of neural crest cell migration. That sounds about right. Incomplete bowel rotation would be like a midgut volvulus. I don't think it's that. Intestinal ileus from exposure to epidural analgesia. Intestinal obstruction from inspissated. Is it meconium ileus? I don't think so. Um, Spinal cord dysfunction due to abnormal tubus closure. I don't know about that. So I think it's A. Let's quickly go over the question here. 2-day-old girl, newborn nursery, abdominal distension, born at term to a 38-year-old who used epidural analgesia. Since birth, she's shown little interest in breast or bottle feeding. She spit up the last feed. Not yet past meconium. Physical exam, the anterior fontanelle is flat, pals intact, and the neck is supple. Cardiopulmonary exam is abnormal, unremarkable. Abdomen is firm distended. That examination of the back shows a shallow 2 millimeter sacral dimple. Digital rectal exam reveals increased tone followed by release of stool, which is classic Hirschsprung. Increased tone followed by release of stool. In other words, explosive release. Okay, Hirschsprung. So Hirschsprung versus meconium ileus. Hirschsprung is because of failure of neural crest cell migration. Meconium ileus is because of obstruction. Um, Hirschsprung is rectosigmoid. Meconium ileus is ileum. Hirschsprung has increased tone, positive squared sign. Meconium ileus has normal tone, negative squared sign. Hirschsprung has normal meconium consistency. Meconium ileus has inspissated. Hirschsprung has dilated proximal colon and small bowel on imaging. Um, Whereas the meconium ileus has only a dilated small bowel and a microcolon. Meconium ileus is associated with cystic fibrosis. Hirschsprung is associated with Down syndrome. Okay, there you go. Hirschsprung transition zone. So you do the contrast enema, and then you can see like this abrupt transition. So that's why you do contrast enema to differentiate between Hirschsprung and meconium ileus. This is meconium ileus. So you see these meconium plugs and then contrast enema demonstrating microcolon. So, and then speed of the fetal occulta, that's what the tuft of hair was kind of getting at. That would cause like neurogenic problems. So, next question. Director of NICU notes an elevated failed extubation rate of 47% among preterm infants. She decides to implement a quality improvement plan with the goal of reducing the failed extubation rate by 30%. Director determines that the primary issue responsible for the elevated failed extubation rate is a lack of standardized extubation strategies. She leads a team to design a new extubation checklist and a standardized protocol, which forms a cornerstone of the QI plan. She provides 4 training sessions over 2 weeks to the NICU physicians and staff, all of them pass post-test administered after their training based on the plan. Do check, act paradigm. Which of the following is the next best step? I hate these questions. So what did she do? Um, she designed a new checklist and then she did a bunch of training sessions and then they all passed the test. So she did the plan, she did the do, she did the check. Now she has to do the act. So what would be this? Implement the new protocol and evaluate variations in failed extubation rates. Sounds about right. Obtaining informed consent from the infant's parents for participation in a formal randomized controlled trial of the new protocol. What? I don't know why you would do that. Request and test institutional review board approval of the new protocol, ensure ethical care, schedule another set of training sessions, send a preliminary report to a hospital leadership with a failed extubation rate, and describe the new protocol. So just, short answer is I don't know. But based on this like thing here, plan, do, check, act. She did the plan, she did the do, she did the check. So next thing should be acting, right? So let's see. Yeah. Yeah, I was kind of wondering what C, like, do we need board approval? Yeah, there's no experiment here, so that's why they don't need board approval. And that's why you don't have to do these like randomized controlled trials and stuff either. It's just quality improvement. There's no experiment here. So, okay. Next question. 15-month-old full-term boy is brought to the clinic for a wild child examination. He has been eating and sleeping well and is meeting all developmental milestones. Has his daycare center had an outbreak of pertussis 6 weeks ago that required it to close for a few days, but the patient has had no symptoms. At age 6 months, he had a generalized seizure that lasted approximately 2 minutes within hours of receiving this vaccine here, this DTaP vaccine. He was taken to the ED for observation and discharged later that day. Patient has had no other seizures or medical conditions and takes no medications. Uncle has a history of childhood onset epilepsy, vital signs, and physical exam are normal. Child is due for the fourth dose of the DTaP vaccine. What is the best next step? Administer the diphtheria and tetanus toxoids, but avoid the pertussis component. Administer the DTaP as scheduled. Administer only tetanus toxinoid. Hold all immunizations. Prescribe only post-exposure prophylaxis antibiotics. So when he was 6 months old, he had a seizure when receiving the DTaP vaccine. But yeah, otherwise, I don't, I don't remember anything about the DTaP vaccine being like unsafe or something. So I'm gonna go with this. Yeah, yeah. So contraindications would have been encephalopathy after previous dose or anaphylaxis, which he did not have those. So anaphylaxis, unstable neurologic disorders, and encephalopathy like coma, decreased consciousness, prolonged seizures within a week of administration are contraindications for future administration, but uncomplicated seizures are not a contraindication. Okay. So it's 4:14 p.m. here, and the coffee shop across from the library I'm at has donuts for 50 cents. So I'll be right back. I'm gonna go get a donut. All right, I got my donut. It's a Bear Claw donut. It's got like apple filling on the inside. It's good stuff. Let's get back to it. Um, let's close that. Okay. Damn, that's good. Got 2-year-old boy is brought to the ED after his parents found a dark red farm stool in his diaper. Eating and drinking well, but seems more tired than usual. Lives on a ranch, raising cattle and goats. He's pale. Fecal alcohol blood test is positive. Lab results are as follows. His hematocrit is low. Platelets are fine. So what's the next step? Abdominal CT, abdominal ultrasound, air contrast enema, bacterial stool culture, cow's milk elimination diet, technetium 99, upper endoscopy. So he's 2 years old. He has like this, he has bloody stool and he's losing blood. But it's like a painless, right? There's no pain. He doesn't describe any pain. So painless, bloody stool, painless. makes me think Meckel. And if it's Meckel, then you want to do that technetium 99 scan. Nice. Nice. Okay. So painless bleeding, uh, without abdominal pain, diarrhea, vomiting is Meckel, and you do the technetium scan for that. The other things, so B and C are kind of pointing towards intussusception, the ultrasound, and edema, and Meckel's can cause intussusception, which you work up with ultrasound and treat with edema. Um, but the patient doesn't have any pain, so that makes intussusception unlikely. Yeah, and then I was also thinking about this milk protein-induced proctocolitis, but that usually resolves by age 1, so he's kind of old for that. 5-day-old boy in the NICU is evaluated for sudden onset vomiting. Patient was born at 32 weeks gestation due to vaginal delivery. Since birth, he's tolerated a mixture of express breast milk and preterm cow's milk based formula, and is administered via NG tube. So we got this preterm kid, 5 days old, who keeps vomiting, and then he's been drinking a mix of breast milk and cow's milk. Patient has had emesis within the last 3 feeds. First 2 were green. The last one was bloody, coffee grounds appearance. Temp is 37.5. Vital signs reveal mild tachycardia. Exam shows that he's drowsy but arousable. Abdomen is okay, and then pneumatosis intestinalis. So this kid has necrotizing enterocolitis. What do we do about that? So just off the top of my head, what do we do about it? We do fluids, we do antibiotics, right? Maybe debridement. So let's see. Blood cultures and antibiotics. That makes sense to me. Continuation of only breast milk feeds. I don't know about that. Laparotomy. Um, if his vitals were like super unstable, then we would do a laparotomy. But my understanding is that he's not that unstable, you know, as he's as stable as a 5-year-old boy with vomiting could be. Corticosteroids, no. Endoscopy, no. So, okay. Yeah. Yeah. So laparotomy was the other option. And let's see. Surgical intervention or laparotomy is reserved for patients with bowel perf. So that would be like free interperitoneal air or clinical deterioration just by medical management. Okay. All right. So let's look at this growth chart. It seems like he's falling off of the growth chart in terms of weight and same with length. So 1-year-old boy has poor weight gain. He's smaller than his peers. He drinks a bunch of whole milk. Uh, eats table foods like meats, fruits, grains. Good for him. Since eating solids foods, he's had an increase in bulky bowel movements occurring 5 to 6 times a day. He also has frequent coughing episodes. Has not had any previous surgeries. He lives in the countryside. Temp is 37, pulse is 120, respirations are 124. He's thin but active. Oropharynx is clear. Palm exam reveals a wet cough with bilateral bronchi. Okay. So what's the most likely cause? Autoimmunity to gluten. So could this be celiac disease? Um, maybe with the symptoms starting after the introduction of solids, maybe. Could it be giardia? That would be like a smelly diarrhea. I don't think so. Constitutional growth delay. No, I mean that would be like a small stature, but like you wouldn't see like this falling off of the growth curve. Food protein induced allergic proctocolitis. It could be that because this has been like since his introduction of fruits and stuff. And like the allergic part could explain the coughing. lactose intolerance. He's been drinking whole milk like for a while though, and then pancreatic insufficiency. That would be like, hmm, could he have cystic fibrosis? Do we see anything here that says cystic fibrosis? He's got the coughing. He's a white cough with bilateral rhonchi. He has bulky bowel movements. Could he have cystic fibrosis? So it's either F or D now. It's either food protein induced allergic procticulitis or cystic fibrosis. Would bowel movements of cystic fibrosis be bulky or would they be more soft? I don't know. And then really, it's this thing where it says since the introduction of solid foods makes me think that the solid foods are somehow the culprit. So it's either D or E. I'm gonna go with D. I mean, it's either D or F. I'm gonna go with D. Yeah, cystic fibrosis. So food protein induced allergic procticulitis, milk protein intolerance typically presents in the first few months of life with blood-streaked stools. This patient's age and the presence of respiratory symptoms. Yeah, the respiratory symptoms don't make sense for food protein induced allergic procticulitis. Failure to thrive and recurrent respiratory symptoms should raise concern for cystic fibrosis. And in pancreatic insufficiency is one of those things which happens in cystic fibrosis, which causes this. Okay, so next question. Sodium 150, potassium 3.8. Okay. 6-year-old boy is brought to the office for evaluation of leg pain. The pain has been intermittent for the last 2 weeks and keeps the patient from playing with his friends. Worse at night, accompanied by headaches. Also wakes up several times nightly to void and has had episodes of incontinence. No fever, dysuria, making me think cancer right now. Cardiac exam reveals tachycardia, tenderness over the right anterior distal thigh. Right knee has full range of motion, no fusions noted. Erythematous papular rashes present over the chest, trunk, and groin. Skeletal survey reveals 2 small, well-defined lytic regions. All right. So Langerhans, I think that happens in like the skull. So I don't think it's that. Oh, but there's one in the skull. So it could be Langerhans, multiple myeloma, the incontinence, and the bone pain makes me think of multiple myeloma because multiple myeloma is crab, right? Hypercalcemia, renal symptoms, anemia, amyloidosis, bone leg, back pain. So he's got the lytic lesions, he's got the bone pain. I don't know about the calcium. He's got the renal. Osteogenesis imperfecta, I don't think so. Osteosteoma, no, it wouldn't look like that. Osteomyelitis, no, he would be like febrile osteosarcoma. It's either osteosarcoma, Langerhans, or multiple myeloma because it's in multiple locations. And it mentions the skull here, my little Langerhans. Yeah. Langerhans cell histiocytosis, proliferation of abnormal dendritic cells, most common from birth, age 15. So bone, so localized pain to the bone, skin rash. So the skin rash I wasn't even thinking about. Skin rash is also a symptom, right, of Langerhans. CNS, polyuria, polydipsia, cough, dyspnea. The incontinence is from central diabetes insipidus. Okay. Langerhans cells on skin bone biopsy, lytic punched out lesions. Here's an X-ray. Yeah. Okay. Multiple myeloma is a neoplastic proliferation of plasma cells. Okay. It usually so kids usually don't get multiple myeloma, and then the incontinence, such as diabetes insipidus, I guess. Oh, also like I should have like actually looked at the labs, right? So the sodium being high could be from diabetes insipidus. I think there's some compensatory stuff that keeps the potassium low. Um, yeah, osteogenesis imperfecta has a bruised sclerae, bone fragility, hearing loss. Osteodysteoma looks like this, so it's not that. Um, Osteosarcoma looks like this, ill-defined bony lesion, and that's not what they described. Okay, next question. 4-year-old boy is brought to the office by his mother due to bruising. Over the last month, he has had several bruises along his chest, back, and legs. Patient normally is very active and enjoys playing outside with his older siblings. However, he has been more tired than usual and takes longer naps. He also has had poor appetite for the past week. His gums have been oozing blood during toothbrushing. He takes no daily medications. Last year, the patient had tonsillectomy with no complications. Paternal uncle has hemophilia. Vital signs are normal. Appears pale and tired. I don't know why the tonsillectomy didn't have complications. If he has a bleeding issue, examination shows a few hematomas on the buccal mucosa. Scattered bruises and petechiae are present on the shins, anterior chest, and back. Huh. This has been happening over a month. Non-tender anterior cervical lymphadenopathy. Abdominal exam shows hepatosplenomegaly. So what would we see a deficiency in? See, the bleeding gums immediately triggered the thought of maybe this is von Willebrand, but von Willebrand would be genetic, and like this is like a new thing. This has been happening over a month. Um, Collagen synthesis, that would be like vitamin C deficiency, where like the bruises don't heal and stuff. I don't think so. I don't see other signs of it. Factor VIII production, again, if it's a genetic issue where he has prone to bleeding, then he had this surgery where he didn't have any complications. Could it be platelet production? Could this be some kind of idiopathic thrombocytopenia? And then vitamin K dependent gamma carboxylation, vitamin K deficiency. So it's either vitamin K deficiency or platelet production. Does vitamin K deficiency cause hepatosplenomegaly? Because hepatosplenomegaly is also kind of concerning here. Maybe this is that. Maybe this is cystic fibrosis, right? You got vitamin A, vitamin D, vitamin E, vitamin K deficiencies, or maybe because of all his petechiae and stuff, maybe it's idiopathic thrombocytopenia. But he's got like more symptoms than just petechiae, right? So I'm gonna go with this vitamin K dependent gamma carboxylation. Let's go. Fuck. Oh man, I should have. Okay. Kid's got cancer, acute lymphoblastic leukemia, occurs between peak age of 2 to 5 years. So non-specific symptoms, fever, or weight loss. I didn't mention any of those. Leukemic cells overcrowd bone marrow, which causes pallor and fatigue and anemia. He has that, right? He's the pallor and fatigue at least. So I wish they would have just like shown us his labs, but that would be too easy, I guess. Easy bruising and petechiae, and then bone pain, which I didn't mention here. Extramedullary spread causes that lymphadenopathy and hepatosplenomegaly. Yeah, because he had the yeah mediastinal mass, leptomeningeal spread. So you want to evaluate with the CBC bone marrow biopsy and lumbar puncture. This is what petechiae look like. So what was it? Why wasn't it D? Factor VII requires vitamin K. In children, vitamin K deficiency is usually seen in chronic disorders of fat malabsorption like cystic fibrosis. But yeah, this kid has no gastrointestinal symptoms and he was previously healthy. So that's why it's not cystic fibrosis. So how does ALL affect platelet production? Yeah, okay, whatever. It impairs platelet production somehow, which causes symptoms. Okay. Newborn Carl is evaluated in the delivery room for respiratory distress. The patient was born 15 minutes ago by spontaneous vaginal delivery. At 37 weeks gestation to a mother who received no prenatal care. Tap is 37, pulse is 176, respirations are 70. Pulse ox is low at 82%. So physical exam shows grunting, subcostal and suprasternal retraction, cyanosis of the lips and tongue. Chest appears rounded, abdomen appears flat. Auscultation reveals absent breath sounds on the left, clear breath sound on the right. Heart sounds are loudest in the right chest. So she has some kind of mediastinal shift. What's the best next step? Broad spectrum antibiotics, chest tube placement, endotracheal intubation, pericardiocentesis, prostaglandin E1, surfactant. So the absent breath sounds on the left with the mediastinal shift, like the heart being on the right side, more towards the right side. Um, it makes me think either two things. It's either a diaphragmatic hernia where the valve goes up into the lungs and causes that shift, or it's a pneumothorax. I'm not sure what caused the pneumothorax, but that's what I'm thinking right now. So if it's a pneumothorax and needed a chest tube placement. Antibiotics, I don't think so. Intubation, I don't see why you do that. Pericardiocentesis, no. Prostaglandin E1, no, because that would be for like a cardiac issue, right? Surfactant, and a surfactant would be for like neonatal respiratory distress. But this whole presentation makes me think thorax. Oh man, yeah. So I was saying it's either a diaphragmatic hernia or it's a pneumothorax, but I didn't know off the top of my head how to treat diaphragmatic hernia or how to manage it. So first of all, it's not a pneumothorax because what? A scaphoid abdomen would not be seen with pneumothorax. Fine. So the first step in management, if you suspect congenital diaphragmatic hernias, endotracheal intubation, gastric tube is placed, should be placed immediately to decompress the stomach and bowel, and then bag and mask ventilation. And that's what it says here. So barrel-shaped chest should have narrowed down the diagnosis. So this just comes down to like bad reading skills on that part. Like I need to like think about everything. Like I just read, oh, he has a flat abdomen. Okay. I should have actually thought about it. So 14-year-old boy is brought to the ED by his parents after sustaining a head injury an hour ago. He was playing hockey and collided with another player, after which he fell and hit his head on the ice. He immediately developed a headache, followed by a single episode of vomiting. He remained awake and his symptoms have since resolved, vital signs are normal. He's alert and oriented to person, place, and time, unable to cite the months backwards. Neurologic exam is otherwise normal. CT scan of the head is normal. He asks whether he may play in a hockey game tomorrow morning. So he had a concussion, and he still has some confusion after that concussion. He's wondering if he can go back and play tomorrow morning. So let's say after 2 days of rest, followed by gradual progression of activity intensity, after 24 hours of physical rest, after strict rest from physical activity for 2 weeks, immediate return, pending a follow-up. So follow-up MRI. So I think after a concussion, you can go back, but I'm not sure if it's a good idea to go back immediately, maybe after 2 days of rest. So let's go with A. Good. Concussion, characterized by neurologic symptoms, headache, difficulty concentrating without structural intracranial injury, initial treatments with cognition and physical rest for 24 to 48 hours, cognitive and physical rest for 24 to 48 hours, followed by gradual return and slowly resume the physical activity. All right. So immediately just looking at this, it looks like Skiffy. And then what's the most likely diagnosis? Skiffy. Femoral neck fracture, like having Murphy's. So it's Skiffy. Let's read this over really quick. 13-year-old kid. He has some right hip pain, muscle strain from skateboarding. He fell while skateboarding. Took some ibuprofen, which helped a little bit. There we go. There it is. Height and weight are at the 95th and 50th percentiles. And I said this in one of my last videos. Whenever the height and weight actually matter, whenever the BMI actually matters, UWorld does this thing where it doesn't give you the BMI. So, um, temperature is 37. He walks with a limp to the exam table, avoid bearing weight on the right leg. So, obese kid with a leg pain and then this like ice cream cone appearance, like this slipped cone appearance. That's good. There we go. 20% of people answered like Happy Perthes for some reason. So let's take a quick look at that. So this is what like Happy Perthes looks like, right? It doesn't look like that. Um, Femoral neck fracture looks like this. Happens in older people. Okay, osteomyelitis. This is osteomyelitis, chronic osteomyelitis. Okay. And then transient synovitis would look like nothing because that's just normal. I mean, it's like bone or hip pain, but like everything else is normal. 5-year-old boy is brought to the office by his parents after exposure to a child with a rash. 2 days ago, the patient had a day-long play with a friend who had low-grade fever, vesicular rash, herpes maybe, I don't know, or pox maybe. That friend and another child in the neighborhood were subsequently diagnosed with chickenpox. Patient has no symptoms and no significant medical history. He has received only one dose of the varicella vaccine at age 1. Lives at home with his mom, father, and brother. Vital signs are normal. Examination of the iris, skin, blah 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 is all normal. What should we do next? So basically, he had exposure to a kid with chickenpox. So do we want to give as a cyclovir? Do we want to give them immunoglobulin? Do we want to give vaccine? Do we want to reassure and observe? So what's his vaccination status? Is what I'm curious about. He received one dose of the vaccine at age 1. So because he only received one dose of the vaccine, I'm guessing maybe he should receive another dose. There's some kind of formula to this. So varicella exposure, varicella immune. Okay. So if he had received both doses of the vaccine, then we wouldn't have had to do anything because he only received one dose. Um, but he's immunocompetent, and that's you do the varicella vaccine. If he was immunocompromised, or if it was a pregnant person, or if it was a newborn, then you would do the Varizig within 10 days of exposure. Okay. This reminds me of an episode of South Park where they purposely give all their kids chickenpox. So, so like, I don't remember why they did it, but that was kind of a funny episode. Um, this is like myeloma. This is Chiari, one of those Chiari malformations, which increases risk of serogomyelua. Because you can see like this part of the cerebellum here, it should not be like below the skull. It should be inside. So 18-year-old guy has headaches, intermittent dull occipital headaches, usually accompanied by nausea, dizziness. Symptoms spontaneously resolve within a few minutes. No history of fever, chills, photophobia. No prior medical conditions. Physical exam, including neurologic exam. So this is the MRI, and then so serogomyelua. So KRA1 malformation here increases the risk of serogomyelua. See, so normally the cerebellum sits up here, like inside of the skull, not outside of the skull. KRA2 malformation. In a KRA2 malformation, the cerebellum herniates through. I think in this case, in KRA1, both the cerebellum and the so the cerebellar tonsils herniate in KRA1, but in KRA2, like the cerebellar tonsils and the vermis herniate. So serogomyelua is associated with KRA1, and then something else is associated with KRA2, which I forgot. Oh, myelomeningeal cell is associated with KRA2. Okay. Cardiac rhabdomyoma is associated with tuberous sclerosis, which looks like this. Optic neuritis is associated with multiple sclerosis. So you see these demyelinated plaques. Parathyroid adenomas, pituitary mass, vesicular schwannomas are associated with NF2. So, okay. 2-month-old girl is brought to the clinic for a well child visit. Her parents are concerned about the back of her head being flat on the right. The infant usually sleeps on her back in a crib, but she sometimes naps in a car seat or stroller. She's breastfeeding well and receives vitamin D supplementation. Birth was significant for full-term cesarean delivery due to breech presentation. Physical exam shows flattening of the right occiput with anterior displacement of the right ear and forehead. Demonstrates a preference to tilt her head to the left while rotating the chin to the right. When the head is turned to the right, there's a firm mass in the inferior portion of the left sternocleidomastoid. Mass does not transilluminate. So I'm thinking this is like congenital torticollis, but also like the mass. What's that? What's that mass? I don't know. So what is it? Lymphatic malformation, fracture of the clavicle, postural deformity of the neck, premature closure of a cranial suture, tumor of the posterior fossa. I'm gonna go with that postural deformity of the neck. Yeah, congenital torticollis. You got his head tilted away. You have the chin pointed away from the contracted muscle. You have the contracted SCM muscle. And I guess positional plagiocephaly happens with this. So this is what they were describing with like the flattening and stuff. And then the mass is from muscle fibrosis. This is a cystic hygroma, which would be a congenital lymphatic malformation. This is craniosynostosis. Okay. 10-month-old girl. So just looking at these rashes here and then looking at the answers, erythema infectiosum, Kawasaki, measles, rubella, scarlet fever. Okay, I don't know. Let's read the question. 10-month-old girl was brought to the office for a rash, low-grade fever for the past 3 days. Rash developed on her face 2 days ago, so cephalocaudal, and then spread to her chest, abdomen, and extremities. So head to extremities means cephalocaudal. No cough, rhinorrhea, nasal condition, vomiting, or diarrhea. Otherwise been healthy. Received all routine vaccinations and stuff. Temp is 38, so fever. BP is 150, pulse is 88. Respirations are 18. Playful infant with small tender lymph nodes in the suboccipital, posterior auricular, and posterior cervical areas. Patchy erythema on the soft palate. Rashes on below. So erythema infectiosum, I think that's, what is that? Is that parvovirus? I think that's what it is. I don't think it's that. Kawasaki would have other symptoms, so it would have like a prolonged fever. How long is this? Is only 2 days, 3 days. It'd have a prolonged fever and it'd have like a strawberry tongue and have some other stuff going on. So it's not that. Measles, maybe. Rubella, maybe. Scarlet fever, maybe. So I'm stuck between three choices here. I don't think it's scarlet fever. Um, because I feel like that would have like less symptoms. It wouldn't be like this. So measles or rubella, cephalocaudal rash, lymphadenopathy, erythema on the soft palate. I think measles would also have like complex spots, but it doesn't really just say that they look to the side of the mouth besides the rash on the soft palate. So I'm gonna go with rubella just because of the cephalocaudal here. Yeah. So erythema infectiosum is parvovirus that has the slapped cheek, right? So there you go. The redness on the rashes, the redness on the cheeks. Kawasaki has a bunch of crap going on. See, fever 5 days, lymphadenopathy, rash, mucositis, conjunctivitis, heart problems, edema. Measles causes a maculopapillary rash that spreads cephalocaudally. So yeah, we got that part. But then it coalesces and darkens later, so it's not that dark. Patients are ill appearing with high fever, coryza, and cough. So this patient doesn't have the coryza or the cough, and the fever's not that bad. So see conjunctivitis, coryza, right? The mucus, coughing, the rash, which kind of becomes darker, and the spots inside of the mouth. So this is rubella. Fine pink maculopapillary exanthem, cephalocaudal, lymphadenopathy, There you go. 16-year-old girl comes to the office for an initial patient visit. Medical conditions include asthma and mild acne. The patient does not smoke or use illicit drugs regularly, but has tried alcohol and marijuana at parties a few times, not sexually active. Maintains average grades at school. When asked about or extracurricular activity, she says that she's thinking about quitting her high school softball team because other girls are mean and I just don't enjoy playing anymore. When asked to describe how she feels, the patient hesitantly mentions that she gets depressed at times and frequently feels self-conscious and that no one likes her. Appears uncomfortable and nervously asks the physician, "You won't say anything about this to my patients, will you? What's the best next thing?" So what did she just share? Basically, she just shared that she's thinking about quitting her softball team because she thinks she's not getting along with other people, and she thinks she might be depressed. Yeah, so like there's no risk for like life here, and then there's nothing illegal happening here. So I don't think you have to share it. So everything we discuss about emotions, drugs, and sexual issues will be confidential. I will not volunteer any information, but must respond truthfully if your parents ask. It's good that you're talking about what's bothering you, but I'm obligated to keep your parents informed. Our conversations are private and will not be shared with your parents except under very specific circumstances. And then the HIPAA protects you for everything. So it's the so under some circumstances you would share things. So yeah, if there is risk, imminent risk, or is threats to safety, that's when you would share things. But otherwise, you can keep the conversation private between you and the physician. 2-day-old kid is brought to the newborn nursery, born at term, to a 30-year-old woman. Pregnancy and delivery were uncomplicated. Mother had regular prenatal care. Only medication was a daily prenatal vitamin. Family history is unremarkable. Patient's length at birth was 10th percentile. Weight was 25th percentile. Initial exam after delivery, ambiguous genitalia. All right, so this is one of those things. Infant has been breastfeeding and has had appropriate urine and stool output. Exam shows an alert newborn with normal tone. Abdomen is soft and no palpable masses. Genital urinary exam reveals severe curvature of an underdeveloped phallus. The meatus is at the base of the structure, flanked by labioscrotal folds. No palpable gonads. Examination of the mother shows no acne or hirsutism. And then here we see like some salt wasting, I guess. Like, I don't know, maybe the sodium is kind of on the lower side. Chloride is high, isn't it? Chloride. What's normal chloride? Chloride is normal too. Bicarb is normal. Blood urea, nitrogen is fine. Creatinine is fine. Calcium is fine. Glucose is fine. XX is the karyotype. Testosterone is super high for some reason. Okay. So alpha reductase deficiency, androgen insensitivity, no, because that would be XY. Congenital adrenal hyperplasia, placental aromatase deficiency. Aromatase converts what? It converts testosterone to estrogen. So that kind of makes sense, doesn't it? And then sertoli, that would be like virilization. Um, but I don't think sertoli would happen in a fetus. So I think it's aromatase deficiency. I think congenital adrenal aplasia would have hyperplasia would have like more abnormalities here. And I don't quite remember what alpha reductase presents like, so I'm gonna go with aromatase deficiency. Yeah. Okay. It's stuff like this, man. It's just like it makes me wonder if I'm ever going to learn, you know. So decreased aldosterone, decreased cortisol, increased androgens. Decreased aldosterone would mean you would have higher potassium, but the potassium is within normal range, and the sodium, yeah, the sodium would be low, but here it's like normal low, right? Atypical genitalia, yeah. Adrenal crisis, I don't know. This kid doesn't have that. Sodium will be low, potassium will be high, glucose will be low. So I guess the low glucose is another sign. Mm. And then you treat that by like replacement of the missing hormones. Oh, okay. In congenital adrenal hyperplasia, electrolyte abnormalities do not happen until age 1 to 2 weeks. So aromatase deficiency is deficient conversion of androgens into estrogens. And aromatase deficiency, the mom would also be virilized. And serotonic would happen later in life. 5-alpha reductase causes defective conversion of testosterone to dihydrotestosterone. Yeah, so this usually presents with like male newborns who have um like ambiguous genitalia until they reach puberty. And then when they reach puberty, their genitalia become normal. Okay. 5-month-old kid is brought to the ED due to abnormal body movements. A month ago, patient began to have occasional episodes in which she appeared startled for no apparent reason. Episodes were brief and occurred only a few times. However, their frequency has increased over the past 2 days. Temp is 37.2, pulse is 160, respiration is 30. During the exam, the patient suddenly flexes at the hips and elbows for approximately 2 minutes. I think that, I don't know, the whole like flexion thing makes me think of dissociation, but let's keep going. Does this several times before crying. Skin examination shows hypopigmented elliptical macules, so capital spots. Mother states that she has similar lesions. There's also intracranial lesions. Which of the following intracranial lesions is most likely to be associated? All right, so this makes me think it's either tuberous sclerosis or neurofibromatosis. I always get those two mixed up. But if this is neurofibromatosis, then you would have that acute schwannoma. I think that neurofibromatosis, you don't see cafe au lait spots, you see more like something else. The spots look different. So I think this is tuberous sclerosis. In tuberous sclerosis, and I think optic nerve glioma is also an NF2 kind of thing, isn't it? Subependymal giant cell tumor, leptomeningeal angiomatosis. So it's either B, C, or E. I don't really know. I'm gonna go with E. E kind of rings the bell in my head. Okay. So optic nerve glioma is a feature of NF1. So NF1. So you see these neurofibromas. That's kind of the cutaneous findings. Oh, so you do see cafe au lait macules in NF1, and you do see scoliosis and optic glioma. So why is this not NF1? Um, oh, because those aren't cafe au lait macules; those are ash leaf spots. Yeah. So how did they describe them again? Hypopigmented. Cafe au lait macules are hyperpigmented. So those are ash leaf spots, and then so subependymal tumors, infantile spasms, intellectual disability, autism, rhabdomyomas, angiomyolipomas, ash leaf spots, angiofibromas, Sjogren's patches. Those are all features of tuberous sclerosis. Okay. And then acute schwannoma was a feature of NF2. And then again, cutaneous plaques and tumors, not hypopigmented macules. So, okay. So I got it right, even though I probably shouldn't have. Okay. 16-year-old boy is brought to the clinic for evaluation of headaches. For the last month, he has had daily throbbing pain in the frontal region that is worse in the morning, occasionally associated with nausea and vomiting. Acetaminophen provides some relief. Also has had severe brief episodes of blurriness in his left eye during football practice last week. In addition to acetaminophen, he takes oral isotretinoin for severe acne. Temp is 36.7, blood pressure is 130/80, pulse is 70, respirations are 15. Patient is sitting up and cooperative with exam. Pupils are equal and reactive to light. Eye exam shows bilateral optic dysedema and decreased visual acuity. Visual fields are full, no neck stiffness. Motor exam reveals 5 out of 5 strength with 2+ deep tendon reflexes and a normal plantar response. Sensory exam is unremarkable, which is the most likely explanation for this patient's symptoms. Cluster headaches, medication effect, optic chiasm glioma, optic neuritis, or viral encephalitis. Okay, let's look at this again. The daily throbbing pain in the frontal region was worse in the morning, and the blurriness in the left eye. So this stuff makes me think cluster. But then he takes this isoretinoin, and then the optic disc edema. That makes me think there's like increased intracranial pressure for some reason. The effects are fine. The optic disc edema, it makes me think there's increased pressure inside the head. It's like some kind of a mass effect that's pushing on the eyelids, on the eyes, increasing eye pressure, basically. Um, and so that would be like a cancer. So that would be like an optic chiasm glioma. This isn't optic neuritis because that's like a multiple sclerosis. Viral encephalitis, no. Medication effect, no. Medicate. Oh, does isoretinoin cause intracranial hypertension? I don't know. Cluster headaches. Okay, so I'm gonna go with medication effect because I feel like maybe this is like isoretinoin causing something, causing the hypertension, but maybe I'm wrong. Let's see. So I had, yeah, good guess, I guess. Good guess. Um, so risk factors are isoretinoin. So retinoids, vitamin A, tetracyclines, and growth hormone can all cause idiopathic intracranial hypertension. And then a recent weight gain or obesity in the woman of childbearing age. Okay. Cluster headaches are unilateral. They appear in the eye region. Most common in men aged 20 to 50. Papilledema does not occur. Optic chiasm glioma can cause insidious headache and vision changes, but with a tumor compressing the optic chiasm, you would expect bitemporal hemianopsia. Um, and we don't see that. So, okay. 2-year-old boy was brought to the office by his parents for evaluation after he lost consciousness earlier today. He was running around at a playground when he tripped and fell, landing on his outstretched hands. He did not hit his head on the ground. The patient gasped and instead of crying, suddenly became pale, lip and diaphoretic. What? And then lost consciousness. So basically, he was running around and then suddenly he became pale and limp and lost consciousness. No clonic movements. He regained consciousness after several seconds and returned to normal activity within 2 to 3 minutes. So there was some post-ictal stuff. Um, Patient has otherwise been healthy, but he had a similar episode a month ago. Temp is fine, blood pressure, whatever, pulse is fine, respiration is okay. Okay, so what kind of testing should we do? Ambulatory EKG? No, because I don't think this is a heart problem because he had that post-ictal like confusion. Like it took him a while to get back to normal activity. CT scan of the head. Could this be like a brain metastasis or something? I don't know. Echocardiogram, electroencephalogram. No testing required. Such a weird presentation. But I'm thinking this is like this question is basically asking, is it a cardiac or is it a neurologic presentation? I think it's a neurologic presentation. But then is it a seizure or is it a brain mass? I'm gonna go with seizure. So electroencephalogram. Wow. Oh, okay. Breath holding stuff. Okay. So here we go. Seizure versus breath holding spell. So breath holding spell at age 6 months to 2 years, increased risk with iron deficiency anemia. Um, Cyanotic breath holding spell is triggered by crying or frustration. Pallid is triggered by minor trauma. Okay, he didn't have any trauma, but maybe he had some pain or fear, I guess. Cyanotic is apnea and cyanosis followed by loss of consciousness, and then pallid. So this is what he has. It's bradycardia, apnea, pallor, loss of consciousness followed by brief confusion. So, and then Yeah, the seizure would also have the tonic-clonic movements. So like this kid didn't have any tonic-clonic movements. So that's why. So the drowsiness after loss of consciousness suggests either seizure or palliative breath holding spell, but then the no tonic-clonic movements. And I guess his vitals showed bradycardia. That would suggest seizures, breath holding spell. So pale, diaphoretic, sleepy, confused. All right. So, and then no testing required. So, okay. Something to keep in the back of my head. Okay. 4-month-old boy is brought to the clinic for a health supervision examination. Born via cesarean delivery at 37 weeks gestation to pregnant gravid mother. Spent 1 week in the NICU for management of hypoglycemia and poor feeding. What? Patient has had no significant issues since discharge and has been feeling well. 99th percentile for weight. Physical exam shows an enlarged tongue. Right leg is larger than the left. So this is asymmetric like growth. So what do we want to do? Abdominal ultrasound, bilateral lower extremity x-rays, brain MRI, chest x-ray, echo, urine homovinylic and vinyl mandelic acid test. So I think this is like a Beckwith-Wiedemann, which presents with a large tongue and the hypoglycemia. So I feel like we should do a brain MRI. I'm not sure. I don't remember everything that's associated with Beckwith-Wiedemann. That's pretty much what this question is asking. But I'll go with brain MRI. It's either brain MRI or echocardiogram, I feel like. Okay. So at least I knew it was Beckwith-Wiedemann. Complications of Beckwith-Wiedemann are Wilms and hepatoblastoma. Yeah, obviously. Okay. So complications of Beckwith-Wiedemann are these two liver things, right? Well, Wilms isn't liver, but it's these tumors. And so that's why you want to do abdominal ultrasound. Yeah, brain MRI, no, that's not associated with Wilms. And then, yeah, you want to ultrasound here because of the leg different discrepancy, but there's no point doing an X-ray. So back with Wiedemann, macrosomia, macroglossia, hyperhemia, hyperplasia, umbilical hernia, and amphiloceal and neonatal hypoglycemia. And then because these kids have an increased risk of Wilms and hepatoblastoma, you always want to do an ultrasound and alpha fetoprotein level testing. And I know for a fact I got this question wrong in the past, and I even have an Anki card on it, which I do every now and then whenever it's up. And, I still got the question wrong. So maybe that says something about Anki. I don't know. 3-year-old boy is hospitalized in the PICU due to management of septic shock. Patient's hospital course is complicated by central line associated DVT in the right subclavian vein. Preparations are made for a continuous infusion of intravenous heparin. Dose of heparin is calculated in units per kilogram, prepared for a per mixed bag of intravenous heparin. Shortly after infusion, the patient becomes unresponsive and cannot be resuscitated. Team discovers that an excessively high dose of heparin was infused. Which strategy would prevent this in the future? Yeah. What is this? You want to use infusion pumps with dosing algorithms and preset limits. I think that's the answer. So shared governance, organizational principles, conducting timeout, required two providers, reviewing checklists. This is one of those cases where like, why is a human being calculating this? You know what I mean? Like, no, you just want to use like mechanical, like the computer can do. And do computers make mistakes? Yes. Do they make as many mistakes as humans when it comes to this kind of stuff? No, no. So, according to human factors and engineering, the most effective error prevention strategies include computerized automation and forcing functions which promote correct action with minimal human effort. Okay. 2-month-old boy is brought to the ED by his parents due to respiratory distress. Parents say the infant has been a noisy breather since birth, but over the past few weeks, he has been breathing harder and faster, pauses frequently while breastfeeding to catch his breath, and spits up after most feeds. Noisy breathing is present in both upright and supine positions, but improves while he sleeps, during which time his back is arched and the neck extended. The patient has frequent wet diapers and normal stools. He's not sick. Vitals are okay, I guess. O2 sat is 96%. Yes, inspiratory and expiratory stridor, mild subcostal retractions. Chest X-ray reveals a right-sided tracheal indentation at T4. Which of the following is the best next step? Dexamethasone, CT angiogram, esophageal pH probe, rigid bronchoscopy, reassurance. So I don't know what this right-sided tracheal indentation at T4 means. I feel like this is a vascular ring because he has inspiratory and expiratory stridor. But then how do we treat vascular ring? Well, I guess first you want to diagnose it right. So I guess CT angiogram will be the thing because vascular ring, my understanding is when like aorta compresses the trachea or something like that. I don't know. So let's see. Yeah, vascular ring. So the biphasic stridor improvement with neck extension is the symptom. And then you want to diagnose it with a chest X-ray, esophagogram, and then CT angiography. So the diagnostic imaging test is the CT angiography, and then surgical correction as the treatment. So this is the vascular ring. The aortic arch has this like other thing on it. So I think like seeing this surgery would be pretty cool. Like I'm kind of curious like how they would treat this here. But yeah. Am I interested in surgery? No. Do I want to see some surgeries every now and then? Sure. But it's not how medication, that's not how medical like medicine works. So vascular ring should be suspected in an infant with biphasic stridor that improves with neck extension. Feeding difficulties are also common. Chest X-ray typically includes tracheal indentation. Diagnosis is made using CT or MRI. So what is this? What is this? Rhabdomyoma, optic neuroblastoma follicles. What is this? Is this? I think this is tuberous sclerosis, right? And tuberous sclerosis is associated with what? Rhabdomyoma, I believe. All right. Kid has seizures, recurrent tonic-clonic seizures, poorly controlled. Seizures have become more frequent in the past month and now occur daily. Patient also has developmental delay, receives speech and physical therapy, born at term without perinatal complications, received all age-appropriate vaccinations. Family history includes mild intellectual disability in the father. Physical exam is notable for multiple 1 to 2 centimeter hypopigmented macules on the trunk and lower extremities. So the hypopigmented macules, tuberous sclerosis. So he's got the subependymal nodules, um, and then cardiac rhabdomyoma is the other thing. Yeah, we just had a question about this. So again, subependymal tumors, rhabdomyomas, and angiomyolipomas, those are the associations. So there we go. That's the brain with the subependymal nodules. These are the Ashley spots. These are the angiofibromas. Next question. 6-year-old girl is brought to the office for a routine health supervision visit. The mother is concerned about her growth and picky eating habits. The patient has no gastrointestinal symptoms. She was born after he's having reached gestation with a birth weight of 2.7 kilograms after an uncomplicated pregnancy. Patient performs well in school, has had surgery for strabismus. Mom is 170 centimeters tall and father is 183 centimeters tall. Height is 2.5 standard deviations below the mean. So what's the height again? I don't know. 30th percentile for weight. Temperature is 36.9, blah, blah, blah. High arched palate, malocclusion of the teeth, short metacarpal bones. So this stuff kind of makes me think congenital syphilis with like the bone problems and stuff. But she's 6 years old, so like that's not what we're asking about now. Yeah, I don't know. She also had to start a business apparently. So, okay, what do we want to do? Calcium supplementation, estradiol, high calorie diet, high phosphorus diet, growth hormone, testosterone. Could this be like rickets? Because, but even then, wouldn't you get vitamin D, not calcium? The weight is kind of low as well. So high calorie diet is what I'm thinking. I don't know though. Growth hormone. Oh, fuck. This is so obvious. This shouldn't have been obvious. It's Turner syndrome. So symptoms of Turner syndrome in infancy, lymphedema, cystic hygroma, and then these weird renal and kidney defects. In childhood, it's short stature and dysmorphic features. So web neck, broad chest, um, getting a bunch of text messages here. Web neck, broad chest, high arched palate. So the high arched palate, cubitus valgus, short fourth metacarpals. Those are all symptoms of Turner syndrome. Like the Thalarchy and Maria, and then you treat that with estradiol. No, I mean you treat that with growth hormone to make them grow normally, and then in puberty you'll give them estrogen. So yeah, growth hormone and estrogen. Let's keep going. See what I mean? Like I know what Turner syndrome is, but do I know all the specifics of it? No. And then that's what just like, bro, like, am I supposed to become an expert in every single subject before test day? Like, who has the time for that? You know, it's frustrating. 3-year-old boy is brought to the office due to intermittent diarrhea and abdominal pain for 1 month. Since age 2, he has had 3 hospitalizations for pneumonia with pleural effusion, osteomyelitis, and purulent cellulitis. Uncle died at 6 months due to infection. So there's maybe some genetic stuff here. Patient is at the 10th percentile for height and weight. Tender left lower abdomen, perianal skin tags, no hepatosplenomegaly or other masses. Lab test reveals a leukocyte count of 12,500, platelet count of 545,000, microcytic anemia. It's got hemoglobin blood. Colonoscopy shows isolated ulcerations in the left colon with normal surrounding mucosa. Histology reveals mild distortion of crypt architecture, cryptitis, and sharply defined epithelial granulomas, pigment-laden histiocytes. What's the next step? HIV serology, oxidative burst test, IgE level, sweat chloride. So HIV is for HIV. Oxidative burst test would be for like a chronic granulomatous disease. IgE level would be for I don't know, and then skin sweat chloride test would be for cystic fibrosis. So let's look back through his symptoms here. He has these recurrent infections, not just pneumonia, but also osteomyelitis, cellulitis. Uncle had an infection at 6 months and he died from it. He's got these perianal skin tags, has microcytic anemia, hemoglobin blood, and then it's got these mild distortion of crypt architecture, cryptitis, and epithelial granulomas with pigment-laden histiocytes. So this is either like IgE being low or it's cystic fibrosis, but it's kind of a weird presentation of cystic fibrosis. Like I don't the skin tags. I've never heard of the skin tags with cystic fibrosis. So I'm gonna go with IgE, test IgE level. because maybe this is like some genetic thing. Chronic granulomatous disease would not like chronic. It wouldn't have all of these other things going on. Like, why does the colon have ulcerations? Why is the crypt architecture distorted? Whatever. So I'm gonna get this wrong. So, okay. So features of chronic granulomatous disease are recurrent infections with callus positive bacteria, staph, Burkholderia, Serratia, Nocardia, Aspergillus, lung, skin, liver, lymph node involvement, and then oh man, diffuse granulomas. So that's what this was. And that should have been obvious. So chronic granulomatous disease can have signs of inflammatory bowel disease with granulomas on intestinal biopsy. Oxidative burst testing confirms that diagnosis. Okay. IgE is associated with eosinophilic colitis and other allergic conditions. Eosinophils, not granulomas, would be seen on biopsy. Cystic fibrosis has chronic diarrhea from malabsorption. Okay. 2-year-old boy seen in the ED for refusal to walk. Just had a camping trip in Arizona. Limping mildly when running. His left knee began hurting yesterday. He's refusing to walk today. He has a fever. Skin over the left knee is warm and edematous. Aspiration of the knee joint reveals a high leukocyte count, and then that's set for culture. Patient is admitted to receive intravenous zinc. After 2 days, the fever still continues and he refuses to walk. What should we add to the medication regimen? Ceftriaxone, clindamycin, doxy, itraconazole, or metronidazole. I don't know. I'm just gonna go with ceftriaxone because I have no idea what's going on here. So I got it right somehow. So this is septic arthritis, and you want to treat for gram-positive cocci with vancomycin. So you treat for staph with vancomycin. But if they have continued symptoms, then you want to broaden the therapy, and that's when you would add ceftriaxone. Itraconazole treats coccidioidomyces, which is endemic in Arizona. But that doesn't happen in kids, and it would happen much later. Metronidazole treats gram-negative and gram-positive, but not aerobes. You don't really use doxycycline to broaden antimicrobial coverage. And then clindamycin doesn't really have good gram-negative coverage. 4-year-old girl is brought to the office by her parents due to frequent squinting of the left eye. Eye also seems more prominent than the right. The left eye seems more prominent than the right. Child was born full term, no problems with birth. Developmental milestones have been normal. Left eye shows proptosis, esotropia, and optic disc pallor. Visual acuity is decreased in the left eye, but normal on the right. Several large cafe-au-lait macules and marked axillary freckling, which thick. So this is one of those things where my scores got me inflated, like higher than it should be because I'm on tutor mode. Because like a few questions back, I just read that NF1 neurofibromatosis type 1 is associated with optic pathway glioma and cafe-au-lait macules. So just from doing that question, I know that this is the answer, optic pathway glioma. So then the other choices, acoustic neuroma is associated with NF2, which presents with hearing loss and difficulty with balance. Craniopharyngoma, it's a rare tumor. Medulloblastoma would present with increased intracranial pressure and cerebral dysfunction. Retinitis pigmentosa would be a binocular issue, not a uniocular issue. Retinoblastoma, uh, rare malignancy in kids before age 2. The kid would have had leukocoria, but these like cafe au lait positive freckling, such as NF1. Okay. 5-year-old girl was brought to the office due to bedwetting. She had been urinating and stooling on the toilet during the day and night, but with no accidents since age 3. However, for the past 3 weeks, the patient has wet the bed nightly. She's also more thirsty than usual, urinates more often during the day, and has had accidents at school. Review of symptoms is positive for fatigue and negative for dysuria and hesitancy. Patient has had no major illnesses and has met all developmental milestones. A month ago, the family moved to a new house after her brother was born. Vital signs are normal. Weight and height are at the 20th and 40th percentiles, respectively. Both were at the 40th percentile. Her well child visit 3 months ago. Physical exam shows a tired appearing girl. Mucous membranes are dry. Rest of the exams are normal. What's the most likely explanation? Autoimmune destruction of pancreatic beta cells. So could this be like a type 1 diabetes? So the weight loss would make sense, the fatigue would make sense, and the thirst would make sense. So it could be that. Bacterial infection, I don't think so. Behavior regression from changes in the home. They did move to a new house recently, but I don't know. Everything else says there's something biologic happening. Excessive vasopressin production. So could this be like an SIADH? I don't think so, because there's like nothing. She didn't take any new meds recently. Functional fecal retention, no. So let's go with this type 1 diabetes. Symptoms of type 1 diabetes are polyuria, osmotic diuresis, polydipsia, weight loss and fatigue. And then in DKA, you have severe symptoms plus abdominal pain and vomiting, free smelling breath. Okay. 12-year-old boy has 2 weeks of itchy red eyes. Vision has had intermittent mild to clear eye drainage without pain or photophobia and rubs his eyes frequently after leading to a burning sensation. Symptoms have worsened. He now has difficulty focusing while at school. The patient has had some light crusting of both eyes when he wakes in the morning. Has a history of eczema for which he uses a topical emollient as needed. Patient lives with his parents and a younger sister who has had fever, cough, rhinorrhea, and pharyngitis for 2 days. Vital signs are normal. Examination shows bilateral diffuse conjunctival injection, mild eyelid edema, visual acuity is 20/20, both eyes, pupils are water reactive. What's the best next step? Fluorescein staining, fundoscopic examination, antihistamines, trimethoprim polymyxin, warm compresses. So, the itchiness here makes me think allergic conjunctivitis, and then the bilaterality also makes me think it's allergic conjunctivitis. And if it's allergic conjunctivitis, wouldn't we want to give topical antihistamines? I feel like you would. If it's viral conjunctivitis, then you would give warm compress, but viral would be like on one side, like it would normally be just one eye. I don't think it would have the itchiness. But on the other hand, the younger sister had this fever, cough, and rhinorrhea and pharyngitis 2 days ago. So it could be either viral or allergic conjunctivitis. But I just feel like the presentation, the bilateral, and then the itching makes me think allergic conjunctivitis. So I'm going to go with the topical antihistamines. Okay. So viral is usually, it could be bilateral, but it's usually unilateral. And then it's 1 to 2 weeks. Allergic is always bilateral, it's watery, and you have this ocular pruritus. So viral would have a viral prodrome. They didn't describe the viral prodrome. They just said that the sister has some problems. Sister had some sickness. Yeah. 1 month old boy is brought to the office for evaluation of blood-streaked stools. Patient was born at full term via spontaneous vaginal delivery and has been breastfed exclusively. Mom says that he usually has 5 yellow CD stools daily, but over the past 3 days, they have become loose and streaked with blood and mucus. Infant nurses every 2 to 3 hours, but spits up a small amount of breast milk with every feed. Mother recently completed a course of antibiotics for mastitis, otherwise takes no daily meds. Weight, length, and head circumference have been along the 40th percentile. Vital signs are normal. Infant appears well, abdomen is soft and not tender, no fissures. Fecal occult blood test is positive. I think this is that, yeah, food protein induced allergic proctitis because it's a young kid, only a 1 month old boy, and then you got this like bloody stools. So that's what I'm thinking. But also like it's only breast milk, right? Breastfed exclusively. So then that makes me think maybe not. Intussusception, no. Lactose intolerance happens later in age, not like right now, not like at 1 month. Malrotation with midgut volvulus, that would have like emesis, abdominal pain. I mean, you can't get abdominal pain in a kid, but it would have like emesis, meckel diverticulum. The blood makes me think maybe meckel. Oh, okay, and then mom recently completing antibiotics makes me think maybe it's C. diff. So I'm not. It's either C. diff or food protein induced allergic proctitis, but because he's breastfed exclusively, I'm gonna go with C. diff. God, I feel like such an idiot, man. Every single day, I feel like a fucking idiot. Is this like if this is how I think, like how there's nothing I can do to fix how I think, you know what I mean? Okay. So food protein induced proctitis, common triggers are cow's milk and soy proteins. Um, Risk factors are eczema and family history. It occurs at age 1 to 4 weeks up to 6 months while appearing blood streaked stools. So if it's a breastfed infant, so yeah, basically it's soy protein from the mom's dairy that's causing this problem. So the mom should restrict soy from her diet. Although antibiotics are a risk factor for C. diff may be transmitted through breast milk, C. diff is rare in infants who lack the intestinal receptors to the toxin until approximately age 2. Moreover, other infectious symptoms will be expected. Next question. 5-year-old boy is brought to the office due to ear pain. 2 days ago, the patient developed low-grade fever and pain in left ear. Parents think he is also having trouble hearing from the left ear as they have noticed him tilt his ear towards the television. Past week, he has had a runny nose and cough. No other problems. Temp is 38.1. Blood pressure is 110/60. Pulse is 110. Bulging of the left tympanic membrane, which is pale yellow and immobile with pneumatic insufflation. Right tympanic membrane and bilateral canals are normal. Nasal mucosa appears boggy. Postnasal drip. What's the likely diagnosis? Otitis media, acute otitis media, barotrauma, bullous meningitis, cholesteatoma, chronic suppurative otitis media, or otitis media with effusion. The left tympanic membrane being pale and yellow. So it's not a fusion because there's like nothing coming out, right? It wouldn't be pale and yellow if it was a fusion. It's not chronic. I don't think it's cholesteatoma, but I don't really remember too well what that was. Bullous meningitis. Again, I don't know too much about that, but I feel like maybe it could be that. Barotrauma, no, because I don't see anything about that in history. Otitis media. So yeah, I'm gonna get this wrong. I'm gonna say bullous meningitis. I'm gonna get this wrong. So bulging of the tympanic membrane, and then the purulent fluid, this yellow, whatever the fuck. So that's symptoms of otitis media. And then yeah, kids are predisposed to it because of their eustachian and tubes being whatever the hell. Pale yellow opaque TM with bulging suggestive of purulent effusion. Okay, barotrauma due to flying can occur, and that can cause TM rupture. There's no history of that. Bullous meningitis is an uncommon complication of acute otitis media with bullae. Okay, so it's not that. Cholesteatoma is an abnormal growth of squamous epithelium in the middle ear and presents with hearing loss and white mass posterior to TM. I don't think it's that. Supraactiva otitis media is characterized by otorrhea and hearing loss for more than 6 weeks. Otitis media with effusion may cause hearing loss and poor TM mobility. But in contrast to acute otitis media with effusion, there is a lack of acute inflammation. So I guess the lesson from this question is like, if you don't know what the answer is, then like don't choose like the weird answer. Like just choose the more common answer. But last question. 1 year old boy with Down syndrome was brought to the clinic for a follow-up visit. He was seen in the ED yesterday due to abdominal pain. Workup revealed a small bowel intussusception that spontaneously resolved at the ED. Patient was discharged home and the pain has not returned. Review of medical record shows that at age 6 months, he developed small bowel intussusception, which also resolved spontaneously. Patient takes no medications other than iron for iron deficiency anemia. Family history is unremarkable. Stamp is 37.3. Abdominal exams was normal. So what other studies indicated? So basically, this guy has recurrent intussusception. What is indicated? Urium edema, colonoscopy, CT scan of the abdomen, nuclear scintigraphy, upper gastrointestinal endoscopy. So what is associated with recurrent intussusception? Hirschsprung is, isn't it? And then this kid also has iron deficiency. So he's got recurrent intussusception, iron deficiency, and he has Down syndrome. But the bowel sounds are normal. So what should we do? Should we do a barium enema, colonoscopy, CT scan? It's either a CT scan or a barium enema. Maybe if we're worried about like maybe that the kid has Meckel's too or something, then we would think maybe barium enema. I just know like with a deception you want to do enema. I don't know if you do colonoscopy on kids. Like I've never heard of like a 1 year old boy getting a colonoscopy. CT scan of the abdomen, nuclear scintigraphy, upper gastrointestinal endoscopy. Barium enema. I don't fucking know. Intussusception is a condition in which the intestine telescopes into itself. Yeah, we know that. Um, Most common lead point is a mecylodiverticulum. Congenital malformation associated in the small intestine, which causes a cough bleeding. Okay, so I was right about like we're worried about maybe there's like mecal going on too, but then you would evaluate that with a scintigraphy with the mecal scan. So educational objective here is that although most cases of intussusception are idiopathic, a pathologic lead point should be considered in those with recurrent intussusception from mecal. So that's when you would do the nuclear scintigraphy. Barium enema can evaluate for Hirschsprung, which unlike intussusception has an increased incidence in patients with Down syndrome. Symptoms may develop after that, but okay, here like the kid has no symptoms. So, okay, let's see how we did. 67. So with it being a mix of incorrect and correct questions, I mean incorrect and new questions, this and with it being on tutor mode, the score was definitely inflated. So I don't feel too good about this. I don't feel very good about like those last three questions I missed, to be honest with you guys. But you know what? It could have been worse. Could have been worse, but I still have a lot of work to do, which is scary because I'm taking an exam in like 10 days. But hey, that's how it went. So hopefully I can have a productive night. I still have so much crap to do. Still have to, still got a lot of stuff to do. But hopefully I have some time to study tonight. So hopefully I can review that maybe tonight. Hopefully I can um, watch some more Dr. High Yield or Divine Intervention. So I don't know. I'll do something productive. But okay. Thank you guys for watching. Good luck if you're studying for the exam too. And yeah, see you next time.